So I have the opportunity here to introduce what is going to be relatively soon my former fellow, as Hans Wang, who I think needs no introduction because he's wonderful and we'd love to have him around here. So I get to introduce Hans as he talks to us about cardiac CT. I don't know if anybody of you know, but Hans is actually a banana slug. He went to the University of California, Santa Cruz, so indeed he was a banana slug. He transitioned from becoming a banana slug to the Medical College of Wisconsin, where he got an MD and also had honors in research. There he had won a number of awards, one of which was was actually nominated for the VA Trainee Award in research. He came to the University of Washington, has been here for his fellowship, has been in my clinic, and it's been a wonderful addition. He is going to be exiting the world of academia and going to Kaiser in a relatively short period of time, which will make all of my patients very sad. But in the meantime, while we have him here, he's going to talk to us about the role of cardiac CT in the evaluation of stable coronary artery disease. Hans.
All right, thank you for the introduction. Let me just get this on. All right. So as Kelly said, the talk today is titled "The Role of Cardiac CT for the Evaluation of Stable Coronary Artery Disease," and I have no disclosures. So as I was preparing for this talk, I think this image sort of resonated with me a lot. I was thinking to myself, as a general cardiology fellow, I'm giving a talk on cardiac CT at the University of Washington with a very strong history in echo, and not just echo, but kind of exercise cardiology with the Bruce protocol. For those of you in the Twitter sphere here, we have the hashtag. But you know, the goal of the talk today is really just to highlight how I think cardiac CT can help us with the evaluation of stable coronary artery disease for our patients. So I want to start by outlining just what I think are the three major needs for cardiac imaging. I think obviously physiology is key. You know, we get a lot of important information from stressing our patients, and that's often done with a treadmill stress test that can be paired with imaging, and we can figure out a patient's functional capacity and ischemia. And obviously morphology is key. Knowing cardiac anatomy plays a big role here. And together with those two things, we obviously can get prognosis. And it's important to understand prognosis as that has implications for how we treat and manage our patients. So the outline of the talk, you know, I wanted to start by talking about coronary artery calcium and focus on coronary artery calcium for the asymptomatic patient for risk stratification. And then the second part of the talk is going to be on coronary CTA for the symptomatic patient with stable chest pain, and touch on basics of CTA imaging, the clinical trials, go over some of the plaque characteristics from CTA, and then at the very end, briefly talk on some new and future applications of CTA. So we just start with a coronary calcium scan. You know, what is it? So obviously it's a CT scan, and the point of the scan is just to quantify the amount of calcium. And it's a low radiation scan. It's less than a millisievert, which is on the order of a mammogram. And the report will give a coronary calcium score, and the higher the score, the more calcium. And the calcium is thought to reflect atherosclerotic burden. So if you have a higher calcium score, then you have more plaque burden. And we have representative images here. On the left, you have a normal scan. In the middle, you have a scan with moderate calcification. On the right, you have a scan with severe calcification involving the left coronary artery. And normally a severe calcification score is typically 400 or higher when we report the calcium score. And something in the moderate range, maybe 100 to 300. And just as these images show, there's no contrast in these scans. So they're pretty quick, no contrast, and really low radiation to do the calcium scan. And I just want to walk through a case example as we're talking about coronary artery calcium. And this is a patient we actually saw recently. So this is a 60-year-old man. He has treated hypertension, and he is self-referred for a cardiovascular risk assessment. He's otherwise active and healthy, and we can see his cholesterol panel here, and it's elevated. We calculated a 10-year risk score of 11%. And he had previously been on a statin therapy, but it was stopped due to side effects of muscle aches, and he'd tried other ones and continued to have side effects. So I think I think the simple question we asked ourselves was whether getting a coronary artery calcium scan in this patient could help us decide if he really needed to be on a statin. And maybe the bigger question is, how should we incorporate coronary artery calcium into clinical practice? If we look at the current 2019 primary prevention guidelines, their recommendation for coronary calcium actually went up from a 2B to a 2A indication. And their recommendation for this is any patient with an intermediate risk or borderline risk based off of their 10-year risk score. If the decision to treat with statins is uncertain, then a coronary calcium score or scan can be considered. And they give a level of evidence B, and then if you get the scan and the score is above 100, or it's greater than the 75th percentile, then the recommendation is to initiate a statin. And if the score is 0, then it'd be reasonable to withhold statin therapy. So I want to just really briefly go into some of the data, which I think shows how coronary calcium can help sort of risk stratify our patients. And there's been decades of data, so I just want to briefly touch on some of the high points. And this is just data from MESA. It's been well established that coronary calcium affects prognosis, and this is 10-year follow-up from MESA, looking at cumulative hard cardiovascular events. And we see on the left-hand side are female, and on the right-hand side are male. And on the x-axis is the years from the initial scan. And these essentially middle-aged individuals who are asymptomatic, intermediate risk, and we can see on the graphs we have the calcium scores labeled. So the top graph is 300, which is a more severe calcium score. And with more calcium, these individuals are having more events. And if you have an individual with a 0 calcium score, the 10-year event rate is low. It's just approaching 5% over 10 years. And if the score is above 0, typically those patients' 10-year events get closer to 7.5% or higher. And there's been other observational data looking at a 0 calcium score. And in those individuals, the annual event rate is well below 1%, and that can be out to 15 years. So it's sort of given way to this idea of a warranty period of a low cardiovascular event out to 10 years and potentially even 15 years with a 0 calcium score. I think the question is, what about in young adults? These young adults often we think of as having non-calcified plaque. We see them in clinic. They have a concerning family history. Does the coronary artery calcium score apply to younger adults? And this is a study looking exactly at that. So they're looking at young adults. It's a prospective community study. And they looked at adults in their 40s, and they had initial scan, and they followed them for 12 years. And they looked for outcomes of major fatal and non-fatal coronary heart disease. And they found a similar finding that in those individuals with higher calcium score tended to have more events. And if you had a 0 calcium score, your event rate was low. It was almost minimal. But even a calcium score of 100% in someone who was young had a pretty significant increase in event rates. So we just go back to our case. We discussed with this patient, and we ultimately ended up referring him for a coronary artery calcium scan. And then we could see here what we saw. And this is a scan that shows no calcium. We don't see any bright white spots of calcium. So it's really a scan I think we would all hope that our hearts would look like as well. And if you give him, he has a coronary artery calcium score of 0. There's really no calcium at all. So he was very happy about this. And I think when we're thinking about putting our patient's calcium score into context, looking at this data, I think is helpful. And this is data from MESA, looking at the effect of either a positive calcium score or any calcium score of 0 and how it affects event rates and statin eligibility. So on the left-hand side are individuals that were just considered for statin therapy based off of their 10-year risk score of 5 to 7.5%. And on the right are individuals who were recommended statin therapies based off of a higher 10-year risk score. And this is all data from MESA. And these are all individuals that weren't on a statin at the time of this analysis. And I think one of maybe the major point here is that among this group of individuals, over 50% of them had a 0 calcium score. And with a 0 calcium score in this group, their 10-year risk was down classified. So on the left, a calcium score of 0 decreased their 10-year event rates to 1.5%. Or those patients with a 0 calcium score had an event rate of 1.5%. And on the right, a 0 calcium score equated with a 10-year event rate of 4.6%. So I think we can see that the current risk calculators often overestimate risk or they're not completely accurate. And I think the coronary artery calcium score can sort of help recalibrate the risk for a particular individual. And if we look at our patient, he had a 10-year risk of 11%. He had a 0 calcium score. And based off of this cohort of patients, we can estimate he may have a 4.6% event rate over 10 years, which is not bad. And I think we felt fairly reassured with that and the fact that he was having significant symptoms that were impairing his quality of life. So we made the decision to withhold statin therapy given a 0 calcium score and a low predicted event rate. So he had a 0 calcium score, and in the world of sort of coronary calcium CT, the term is called the power of 0. And if you Google the power of 0, the first 100 hits are this finance book, and it's talking about really how to get into 0% tax bracket, which sounds great, and it's how to transform your retirement, but that's not exactly what we're talking about here. It's the power of a 0 calcium score, and it's really just the ability to down-classify a patient's risk and potentially withhold statin therapy for a period of time. And I think the next question is, what do you do with a positive calcium score? If somebody has a positive calcium score, what should we do? And you know, we know that if they have a positive score, their risk is increased based off of the observational data. But interestingly, there really hasn't been any randomized controlled trial data to suggest that if you have a positive calcium score and you treat those patients with statins, that they have better outcomes. And the closest thing we have is this St. Francis Heart randomized trial, which was back in 2005. And they looked at patients who were asymptomatic and who had an abnormal calcium score. And they were older individuals, and they randomized them to a TORVA 20 and placebo, and they looked at a composite cardiovascular endpoint. And they followed them up for over 4 years, and they did see a pretty dramatic decrease in event rates from 9.9 to 6.9 with treatment. So it was a 30% reduction, but it didn't reach statistical significance, likely because the study was underpowered or the follow-up time wasn't adequate. So I'm sure if we had more patients or followed them up longer, we would have seen a significant decrease. So I think with the signal from this trial, knowing that their event rates are increased from some observational data, I think most of us, at least from the recommendations of the guidelines, would favor starting statin therapy in anybody who had a positive calcium score. I will say there's been other attempts to fund a randomized trial for coronary calcium, but because it would require enrolling tens of thousands of patients and require significant financial costs, really getting these approved or funded has been unsuccessful. So I think we step back and we put it all together. Kind of this is my algorithm to follow for checking coronary artery calcium score and sort of management. And I kind of break it down into 2 basic groups of patients who may benefit from coronary artery calcium testing. I think really patients who are reluctant to initiate statins for whatever reason. Maybe they want to know their risk a little bit more or have a better idea what their risk is, or they may not tolerate a statin. I think this is a reasonable group to check a coronary artery calcium score. I think the second group is also young patients with concerning risk factors like family history. I think with these patients, the risk calculator doesn't totally capture their risk, and sometimes they're just too young to even be incorporated into the score. So I think having another way to refine their risk can be helpful. I think with a 0 calcium score, I think we have the data to say you can withhold statin therapy and then reassess in 5 to 10 years. And it's a little bit controversial, but the guidelines would say to check another coronary artery calcium score or scan in 5 to 10 years, along with sort of an overall risk evaluation. And if any of those patients have any positive calcium score, again, I think the data would support us favoring or at least starting statin therapy in those patients. So I hope I was able to at least show how in an asymptomatic patient, we can use coronary artery calcium to help with risk stratification and prognosis. So I want to switch gears and move to morphology and look at cardiac CTA for the evaluation of stable chest pain or coronary artery disease. So these are just some representative images of coronary CTA, and now the focus is on anatomy. So the coronary calcium scan is really just trying to quantify calcium. We're not looking at coronary anatomy or luminal obstruction. Here we're giving contrast, and really the focus is on getting really good picture images so that we can look for any coronary disease. So it's really like a non-invasive angiogram is one way to think of it. And we can see on the upper left is a normal coronary artery and a good image quality. And then at the center of the screen at the top with the yellow arrow is a coronary artery with a significant obstruction that we're seeing there. And then the bottom images show bypass grafts. So with coronary CTA, we're able to get a pretty good view of bypass grafts in the anatomy. And I think someone who always struggled in the cath lab to engage bypass grafts, it's nice to be able to just sit here at a computer, use a monitor, and just kind of look at them that way. So this is really nice. And then you have your 3D image that just rotates around like that, which I don't know how much it adds, but it certainly makes for these nice presentations here. So I think the question is, how do we get these images? And really, the key here is slowing the heart rate down. You really want to image the coronaries when they're not moving, and that's usually in mid-diastole. So if you slow the heart rate down, diastole is prolonged, it's just easier to obtain good quality images. So the key here is beta blockade, which is typically given an hour before the scan, and we usually aim for a heart rate around 60. And then giving nitroglycerin around the time of the scan to help dilate the coronary arteries to enhance image quality. And it's also helpful to have the patients take a breath hold during the scan just to try to get rid of some of the respiratory motion. So if you go on YouTube, you can actually find pictures of or videos of these scanners, and some of these people were crazy enough to take the cover off the scanner. So at the top is the GE Revolution scanner, which we actually have here at the University of Washington, and the bottom is the Siemens flash scanner at Harborview. And what's interesting here is you can see, and I put a cartoon here, you can see where the X-ray source is, and then you can also see where the detector is, and that cartoon is showing where the X-ray is coming out and hitting the detector. And that makes up what we call the gantry, and that spins around the patient very fast. And the faster it spins around, the faster we can acquire images. And I think here you can kind of get a sense, if the video plays, of this spinning around. And really with these newer scanners and the detector size, we're able to image the heart, the entire heart, in really one heartbeat. And because of that, I mean, that means there's less radiation with these scanners, and there's less contrast that's needed with these scanners. And also there's less of a requirement to get the heart rate down with some of the newer scanners that have really high temporal resolution. So fortunately, there is a cover on them, because I think most patients would be pretty terrified to have to go through one of these. Although it's probably safest to be in the center of these scanners. If anything happened, it's the people around that's going to cause the issue. So it's great when we can get nice images, but there are times where we have impediments to optimal CT imaging. And I think one of the big ones is when you have heart rate variability. And that can give you an artifact like this. It's sort of a stair-step or band artifact, and it's kind of like what we see with 3D echo. And when you have an irregular heartbeat, we can get this stitch artifact. So I think of it the similar way with CT. And then obviously calcium and stents can create issues. There's a blooming artifact. So if you have calcium or stents, their edges can be blurred and obscure the lumen of the coronary artery, and it can be hard to really visualize the actual lumen and to know whether there's a true obstruction or if it's just non-obstructive disease. So in that center screen, you can see a lot of calcium. So in those situations, it can be really hard to evaluate that segment. Sometimes we just can't evaluate it. And I think that's one of the limitations of CT right now. The bottom is an example of an obese patient, and that's also an issue. So if you have an obese patient, there's more soft tissue, there's more tissue for the X-ray to penetrate, and you get more attenuation of the signal, and then the image is degraded. So I think these are all things to consider as you're thinking whether coronary CTA may be an option for your patient. And these are some of the factors that get in the way of us getting nice pictures. So what about the radiation? I mean, this is a big thing that people always talk about. And the top is a protocol we typically use. It's a prospective triggered CTA. And the radiation there is 1 to 4 millisieverts, and it's usually here at UW, it's usually 3 to 4. Some of the newer technology, these high-pitched CTA scanners they have at Harborview, can get down to less than a millisievert. And just for reference, if you think about an abdominal CT, that's on the range of 5 to 10 millisieverts. And if we compare that to sort of our standard nuclear imaging or other diagnostic tests, you can see with a SPECT nuclear stress, it's 10 to 12, and then rubidium PET is around 5. So I think some of the newer scanners with the newer protocols in terms of radiation compare favorably to what we currently have. And then if you can see just sort of a general comparison to ambient radiation, someone walking around at sea level for a year has slightly about the same radiation as a single CTA scan, and then a round trip flight and then a chest X-ray. How does the CTA perform from a diagnostic standpoint? Well, if you compare CTA to other imaging modalities, CTA is on the very right-hand side of the screen, and then the comparison here is invasive cath. And I think we can see that with CT, the sensitivity is really high. I think that's really the benefit here. And with the really high sensitivity, the negative predictive value is going to be high. The specificity is modest compared to some of the other modalities we have, but I think it's comparable. I think we can see PET has reasonable sensitivity and specificity, but I think the take home here is that CTA is sensitive, it has a high negative predictive value, and it's really helpful for ruling out disease. So I just want to jump to just a second case as we go into CTA. So this is a very standard referral we get from our friendly neighbor care clinic colleagues, and it's a 55-year-old woman, treated hypertension, presents to clinic with several weeks of atypical chest pain. That's her main symptom. And then she kind of mentioned she has some shortness of breath on activity that may or may not have started before the chest pain. So the question is, is a coronary CTA an option for her? And I think it's interesting to look at if she were in the UK, if she were in Europe, what would they do for her in terms of her work up there? And these are the guidelines from the UK. And we can see if we sort of put our patient into the context of these guidelines, they break it up into typical, atypical, or non-anginal chest pain. So if she has atypical chest pain, she'd be going down that algorithm on the right. And the first line test in the UK is a coronary CTA. So if you're in the UK and you have chest pain, typical or atypical, your first test is going to be a coronary CTA. If you have an equivocal or non-diagnostic CTA, then a functional test can be considered sort of a second line test. And then obviously if it's non-anginal pain, then they consider a non-cardiac workup. So I think the point here is their emphasis is really on coronary CTA for the evaluation of stable chest pain. Now, if we go to the ACC/AHA guidelines for a similar evaluation of stable chest pain, we can see the algorithm here. So if you have stable chest pain, suspected ischemic heart disease, you can exercise, your ECG is interpretable, then really you're looking at a standard exercise ECG test, or you're looking at an exercise test with some form of imaging, nuclear or echo. If you can't exercise, then you go to pharmacologic stress, class 1 indication, and it's only then that the coronary CTA sort of pops in at a 2A indication, kind of an afterthought. It's the second line test for stable chest pain if you can't exercise or for some reason you can't get a stress test. So there's a big difference. You have here, you have Dr. Bruce, who's really the pioneer of exercise cardiology, and with the ACC guidelines, really the focus is on exercising your patient. And this treadmill test has really stood the test of time. And then you go over to the UK and you see that the CT scanner in the last couple of years is really your first line test for the evaluation of chest pain. So it's a really kind of major difference in how we approach chest pain here versus how they do it in the UK or in Europe. And in their analysis, one of the major driving points for putting CTA up was actually improved cost-effective analysis that they found. But I think in my opinion, I think there's a role for both. And I think we can start to consider coronary CT more as an equivalent test to functional stress testing in the right patient. And I hope to show some of the data that I think supports the role of coronary CTA being viewed as more of an equivalent test to a standard stress test. I don't think we should be looking at it like the UK where it's the end-all sort of be-all first-line test, but I do think it has more of a role than what we currently have in our ACC guidelines. So some of the major trials, PROMISE and SCOT-HEART, these are trials for stable chest pain. So there's a lot of trials for acute chest pain in the ER, which I won't go over. These are just the stable chest pain CTA versus functional testing trials. So PROMISE looked at over 10,000 patients with suspicious symptoms for CAD. And these are low intermediate risk patients who had atypical chest pain. They randomized them to CTA versus functional testing. They followed them for 12 months or up to 2 years, even 3 years. And I think the important points is those tests were read locally, and all subsequent testing or management changes were left up to local providers in the trial who were taking care of these patients. So what did they find? Well, they found no difference in the primary outpoint, which was death, MI, unstable angina, or major procedural complications, really out to 3 years. And you could see the hazard ratio and the p-value there. Overall, there are low event rates in this trial, so really just kind of over 3% at about their median 2-year follow-up. I think an important secondary endpoint that they looked at was the rates of 90-day cath and revascularization rates. And I think it's important to keep this in mind. So in the CTA group, and this is a pie chart on the bottom left, and the light blue is those that were sent for invasive cath, purple is those who were not sent for cath. And we can see that 12% of the patients in the CTA arm actually were sent to cath. And then among those sent to cath, about half underwent revascularization, and then 28% were found to have no obstructive disease. And they actually didn't report the remaining 21%. It wasn't there when I looked through the manuscript or kind of the supplemental figures. So it's not really clear what they saw, but maybe you can assume it was obstructive disease that was just treated medically. And if you compare that to functional, you can see, again, 8.1% were sent to cath, so slightly less. And then among those that were sent to cath, 9% underwent revascularization, and then about half they found no obstructive disease. So I think when you look at this, you can say that, well, if you had a CTA, you're more likely to be sent to cath, and you're more likely to get revascularized. But there's no really difference in clinical outcomes. They had really much the same. I think maybe if you were pro-CT, you would think another way to look at this is that CT sort of made the cath lab more efficient. When you're sending people to the cath lab after a CT, you're less likely to find normal coronaries, but you're more likely to find disease that could be intervened on. So this kind of led way to SCOT-HEART a little bit in the sense that in PROMISE, they were comparing functional testing directly to a CTA strategy. And then SCOT-HEART came along, which is the second trial, and said, what if we add CTA on top of standard of care and just add it to standard of care and then compare it to standard of care? And in this case, the standard of care meant most of those patients got an ECG exercise stress test. So this is the second of the two major trials for CTA and stable chest pain. And this is the one that was done out of the UK. And they randomized just over 4,000 patients. Again, these are low intermediate risk patients. And these patients actually, a higher percentage had typical chest pain in this trial. And 80% of them actually underwent an exercise ECG test first, and then they were randomized to CTA or to standard care. And in the standard care group, they were given this assigned score, which we can think of as sort of like a Framingham risk score. And one of the key differences here is that in this trial, the CTA results were given to the providers with specific recommendations on what to do with the results. And there was also prompting from the central trial committee to prompt the providers to act on the results of the CTA. So they followed them up for about 5 years, and these are the outcomes that they saw. So at 5 years, and their primary outcome was coronary heart disease death or non-fatal MI. They saw a significant reduction in favor of CTA at 5 years. So there's about a 41% reduction in the primary endpoint. And one of the interesting points is early on at the beginning of the curves, they really overlap. And it wasn't until 50 days out there there's actually a separation of the curves. And that was felt to represent the time it took to start medical therapy after the CTA results, so some of that delay. So they said there was a 41% lower rate in the CTA arm versus standard care at 5 years. They found no difference in invasive cath and revascularization rates at 5 years in this trial. Early on, there was slightly increase in revascularization rates, but that evened out at 5 years. And I think one of the interesting points is they found that among those that went to CTA, a large proportion had non-obstructive disease. So about 38% had non-obstructive disease, and then 37% had normal, and then the remaining were obstructive. So again, the providers in this trial were given the CTA results, and then they were given recommendations on what to do with the results. And they were prompted to start medical therapy for abnormal CTA. So it's not surprising when you look at medical therapy in this trial that when you compare standard care, which is the red bars, to the blue bars, which is the CTA arm, that more of the patients in the CTA arm were treated with medical therapy. And this is a chart of statin therapy. So throughout the 5 years of follow-up, there's a higher percentage of patients in the CTA arm that were receiving statin therapy versus the standard of care. And then we see when you look at antiplatelet use, there was actually a similar bar graph showing higher antiplatelet use in the CTA arm versus standard of care throughout follow-up, and then at 5 years, the percentages are shown there. So I think this really brought up the idea that, again, these patients were getting a CT, they're finding more non-obstructive disease on CT, and those patients were being treated more with the CT group. So I think that raises this question of, does finding non-obstructive disease matter? Is it important to recognize the difference between a patient with normal coronary arteries and a patient with non-obstructive disease? And this is data from the CONFIRM multi-center registry, which enrolls patients who have undergone a CTA for stable chest pain and it follows them for outcomes. And here we can see on the y-axis is the survival probability, and on the x-axis is the survival time. And we can see, not surprisingly, that when they had more coronary artery disease on CT, that they had an increased risk. And the top curve is those with a normal CTA, and they had a very low event rate out to 3 years. And then non-obstructive disease had an increased event rate or decreased survival. And then it worsened with multivessel obstructive disease. So I think when we think about this paradigm of treating non-obstructive disease and its impact on outcomes, I think it's interesting to sort of go back and compare the two trials. So we see again with PROMISE that there was no treatment algorithm for the results of the CTA. And in SCOT-HEART, they instituted a treatment algorithm for obstructive and non-obstructive disease with the CTA. And what did they find? Well, they saw that in both trials there was an increase in preventative therapies. In PROMISE, about a 1.7-fold increase in preventative therapies in favor of CTA. But SCOT-HEART is actually a 3-fold increase, and maybe even higher if you just looked at aspirin in the CTA arm versus standard of care. PROMISE had no difference in outcomes, and then SCOT-HEART had a significant reduction in MI with CTA. But I will say that there's more than just this that accounts for the difference in outcomes. I think it's important to note that they're just a different trial design, and they're really asking a different question. SCOT-HEART was adding CTA on top of standard of care and comparing it to standard of care, and PROMISE was really just comparing CTA directly to functional testing. So given the success of SCOT-HEART in finding more non-obstructive disease and treating it and better outcomes, there's really been a renewed emphasis on how we report CTAs. And this is the standard reporting system called the CAD-RADS. And what it does is it systematically pairs the severity of disease with specific management recommendations. I don't think this applies necessarily to the cardiology audience here, but maybe to the primary care person who's referring the patient, this may be more helpful. But we can see with an increasing CAD-RADS score that the severity of coronary artery disease worsens. So with a CAD-RADS of 1 or 2, that's non-obstructive disease, and the recommendation there is preventive therapy and risk factor modification. And then we could see with CAD-RADS 3, it's moderate stenosis. Again, the same recommendations in consideration of functional testing for this sort of intermediate stenosis. And then with more severe disease, it's guideline-directed medical therapy with consideration of revascularization if clinically indicated. So just quickly going back to our patient, she had atypical chest pain, and we ended up referring her for a coronary CTA, and here are the results. So overall, she had non-obstructive disease. Her RCA is to the left, her LAD is upper right, and her left circ is bottom right. And a lot of this was well below 50%, and if we were to classify her CAD-RADS score, she gets a CAD-RADS of 2. Based off of this, we instituted high-intensity statin therapy along with aspirin. And her symptoms ultimately resolved. We never quite figured out what it was, but she went back to her normal active lifestyle, and she had a resolution of her symptoms. So I think the next thing this brings up is that, yes, we can see obstructive and non-obstructive disease, but is there anything else we can pick up with CTA in terms of plaque characterization? And the question is, do plaque features matter? And a lot of this work has been done out of Japan, where they've been actually able to look at specific plaque features that correlate with culprit lesions in patients presenting with acute coronary syndrome. And what they found are these 4 characteristics. So one of them is low attenuation plaque. Essentially, if you measure the Hounsfield unit or the density of the plaque, it's low on CT. Or positive remodeling, where the outer diameter of the plaque grows outward relative to the normal vessel. And then spotty calcification, where you have small areas of calcification in the plaque. And then the most scientific of all of them here is the napkin ring sign, which, again, these are pretty subjective, but I do think the top 2, there are sort of more objective measures to determine if they have high-risk plaque features. And the question is, do these matter? And there's been some data that suggests that these high-risk plaque features may be associated with worse outcomes. And this is just secondary analysis from the SCOT-HEART trial, where they looked at the effect of high-risk plaque on either obstructive or non-obstructive disease. I think it's a busy graph, but I do think it's interesting. And again, their outcome here in SCOT-HEART was coronary heart disease death or non-fatal MI. And they found that if you had obstructive coronary artery disease with high-risk plaque features, those patients had the most events. Obviously, if you had normal coronary arteries, which is the blue graph at the bottom, those patients had the lowest events. And if you kind of clean up this slide and get rid of all that, you're left with everything else. And I think one of the points here is that if you had non-obstructive coronary artery disease with high-risk plaque features, which is a solid orange line, you actually had comparable results at about 2 years to those who had obstructive disease without high-risk plaque features. But this is a secondary analysis of a randomized trial that was not powered to really answer this question. So I think at most this is something that's maybe kind of hypothesis generating, but there's really more data that we need to look into these high-risk plaque features to really determine if they predict outcomes. So I think this slide here kind of gets at some of the unique opportunities of CTA, that we can see normal coronary artery, we can rule out disease, we can see non-obstructive disease, and we can see non-obstructive disease with high-risk plaque features, which may have an impact on outcomes. And if this is all non-obstructive disease and they're not really flow-limiting lesions in the setting of a typical nuclear stress test, this may turn out to be a normal study. And the CTA may be able to pick up sort of subtle non-obstructive disease. I will say, if you're getting the nuclear stress test and you're able to exercise the patient, you also get very valuable prognostic information that we're not getting with CTA. So it's somewhat of a trade-off in the sense of the CTA giving you more idea of atherosclerotic burden, but you lose really the functional component that you get with exercise. So I think when you sort of summarize or my kind of takeaway from the data, so I think coronary CTA has benefit, but not for all. I think if you look at PROMISE, I think PROMISE is the one trial that probably applies to us the most in terms of directly comparing CTA to a functional stress test. And we saw that they had clinical or similar clinical outcomes, although they did have increased rates of going to cath. So I think that is something that we need to work on with CTA, but if you just look at clinical outcomes, they were similar. I think if there are benefits to CTA, they're probably driven by changes in preventative therapy, by increased preventative therapy, by identifying non-obstructive disease. And we saw that in SCOT-HEART. So just practically speaking, when to consider CTA, I think it goes back to sort of the low intermediate risk patients. CTA gives us that high sensitivity. So it really allows us to rule out coronary artery disease. So I think if you have a low intermediate pretest probability, and really the question is, do they or do they not have coronary artery disease? Can we rule it out? I think CTA is a good test for that. And maybe if the diagnosis of non-obstructive disease would change medical therapy and potentially alter how you would treat the patient, I think that might be a reason to consider CTA. And certainly if you're looking for additional information, anomalous coronary arteries or ruling out PE or looking for pulmonary disease, I think a CTA gives you that added benefit. I think the one big limitation here, I think that we all realize, is that CTA does not have any functional information. There's no exercise, there's no physiology. So that remains to be a big limitation of CT. And I think until we get that sort of, it's going to limit CT's ability to be more widespread and to be used on higher risk patients. So that brings me to the last part here, is the next frontier of coronary CTA. And it's really combining coronary CTA anatomy with function, really to get anatomy and then to get functional all in one test. And I'm just going to briefly, in a couple slides, just touch on this. But one of the newer technology is FFR-CT. I'm not going to be able to explain it because I don't have a PhD in physics here. But really, what it does is it's using CT images to model myocardial blood flow, and they're able to estimate FFR, and they're actually able to essentially model what the effects of vasodilation or adenosine is. So they're able to give an FFR value to the specific lesion on CT. And this is done by a proprietary software at this point. So if you have a CT image, you would send your study out to the Bay Area, which is HeartFlow, and then within 5 hours, they would send you back this pretty 3D model of the coronary tree, and you'd be able to sort of manipulate it, and determine if the particular stenosis is positive in terms of the FFR. And there's been some preliminary data to suggest that, to show that there's actually improved accuracy when you add FFR to standard coronary CTA imaging. But I think at this point, in terms of how we do it, it's still a little bit of a black box. We're sending them the images, we're getting back this FFR. But there's more exciting and new data coming out on this. And then what's been done here, and a lot of work done by Dr. Branch here, is CT perfusion. Again, using the CT scanner, looking at anatomy, and then adding a stress agent like a vasodilator, and then looking for perfusion. So these are all ways we can try to get physiology information from a CT scanner. So I think if we try to take it back, I hope I was able to show that with CT we can get prognostic information from the coronary artery calcium scan, but also just from the coronary CTA anatomy and plaque burden, the morphology. I think with coronary CTA, with the right patient, we're able to really look at the anatomy of the coronaries. And then I think physiology is sort of still a work in progress and probably not ready for prime time, but there is some promising technology there. So my take-home points: coronary calcium, I think you can think of it as really a strong negative predictive value and being able to rule out statin therapy. And I think based off the PROMISE data, I think we can start to think of CTA being at least equivalent to stress testing for detecting coronary artery disease and having similar outcomes with low intermediate risk patients. And I think CTA, if it can improve outcomes, it's going to be by promoting and targeting medical therapies to patients that actually have coronary artery disease. And as I said, I think functional assessment with CTA is possible with FFR, CT, and perfusion, but we're not there yet. And we'll see kind of what the next few years will bring us. I just want to acknowledge Dr. Branch, Dr. Wong, and then Dr. Krieger for this presentation. That's all.
Okay, any questions? Catherine.
That was a fantastic talk, and that's really, really interesting. I think one of your second point about using CTA in low to intermediate risk, actually a lot of the stress tests we do now are not in people who we think have coronary disease or who have symptoms, but they're in people who've had a heart transplant or who are going to have a liver transplant. So they're like pre-surgical testing or post-transplant. So how about using CTA in those populations?
Yeah, I don't know if we've actually looked at it in those populations. I think it's interesting because we think of using an exercise or functional stress test because we want to get the exercise component of it, but we don't exactly. And so I think coronary CTA certainly would be something to think about. I guess my question would be, if they truly low intermediate risk, I think coronary CTA could be an option, but I just don't know really the data in coronary CTA for a transplant patient or for the preoperative patient.
Can I step in?
Yeah.
Okay, so there actually are data that looked at...
Correct me.
Sorry, yeah. Well, some of us have been doing this a few more years, Anyway, so for the heart transplant patients, there's actually a reasonable literature out there. The problem is, of course, that this is such a diffuse disease that without the plaque characterization, which is actually relatively recent, only about the past 3 years or so, people have really started doing these advanced plaque characterization algorithms, and are only available in a couple places. So there are definitely data that are out there, but it doesn't get to the physiology just because it's such a diffuse disease. In liver transplant, there have been some small studies which have been conducted because they're already doing the multi-phase, and all they have to do is just cut up a little bit higher, and they can rule out coronary disease. So it actually would save us from the misery of dobutamine stress echoes in all these patients. So that we've talked about doing this as a study here. It just hasn't been something that's been solidified.
Yeah, that was a really great summary. So, one could think of SCOT-HEART not as a test of coronary CT, but as a test of the value of disrupting clinical inertia, which is the tendency to keep treating patients the same way you've always treated them and not think that maybe we should approach them differently. Have the data been looked at with that in mind? In other words, the patients who eventually got switched over to more intensive medical therapy, if they were looked at more critically, would they have been switched over anyway based on clinical criteria?
Sorry, I don't, so if...
Were people undertreated and then properly treated, and could that have been picked up with, say, better application of risk scores rather than sending them to CT?
Yeah, and I think that's the question. I mean, do we really need to have a CT scan with radiation and cost to make this decision about treating medical therapy? Is there a better non-invasive score that we can use to do that? I'm not available of anything that can do it better. I think this is the one trial that has shown that this is maybe an expensive but effective way to get patients on better medical therapy. But there is some work I know with the PROMISE trial and using a PROMISE score to see if we can sort of better risk stratify these patients and try to avoid a CT scan. Because ultimately the question is, we just want to get them on medical therapy and we want to be able to target the right patients with the right therapy. And how can we best do that? That can be done non-invasive with a score, that's great. But I think right now this is the most convincing data that shows that CTA seems to do this the most efficient, but there is some work being done looking at other tools and scores.
Yeah, it was really a terrific talk. So I have a couple of questions. So the first is with regard to yours, David, and clinical inertia. I mean, they were given, in both groups in SCOT-HEART, they were given recommendations. So was there a higher proportion of more aggressive recommendations in the CTA group, or was there a difference in overcoming clinical inertia? I mean, was the adherence of the providers to recommendations, did they differ between the two?
Yeah, I mean, I think certainly, I think a little bit of both. I mean, I think if you look at the CTA arm, I think so they gave them this framing and risk score for the standard of care arm. And I think those patients certainly didn't get as much medical therapy. So I don't think it was as sensitive as the CTA in picking up the disease. So less of those patients, the cutoff was 20. If your score is above 20, you're starting on therapy. So just less patients were started on therapy. The CTA just picked up more disease and they just put more patients on therapy. But not just that, if the CTA showed negative or normal coronary arteries, and those patients were actually stopped, a lot of those patients stopped taking medical therapy, and then the patients that had disease were put on medical therapy. So it was sort of kind of redirecting medical therapy targeted at patients with coronary artery disease. So I really think it was just the fact that the CTA was more sensitive in picking up the disease, and that's why those patients got put on medical therapy. I think you could argue that maybe there's some bias that, you know, these aren't unblinded randomized trials. So if the providers and the patients knew that they had the CT, maybe they were more aggressive in treating them. There's probably a component of lifestyle changes. If the patients saw that they had abnormal coronary arteries, maybe that affected their lifestyles well. I'm sure that contributed in addition to the medical therapy for the outcomes.
It seems like if I'm not mistaken, the PROMISE trial.
I think you cut off Dr. O'Brien.
Oh,
Yeah, right.
Yeah, sorry, man. Yeah. Fellas can ask questions.
So really quickly, so if coronary CTA has by far the highest sensitivity, probably the best negative predictive value if applied in a group of people in a population with low to intermediate risk, why would we ever use another testing modality?
Well, so the limitation for CT, if you start getting into intermediate disease, so let's say 50, 70%, I think that's where CTA struggles a little bit. And we know that anatomy and physiology don't always correlate. So if you have a 50% stenosis on CTA, you may ask yourself, is it hemodynamically significant and is it causing the patient's symptoms? And you can't tell that just by looking at the CTA. If they have non-obstructive disease or it's normal, that's great. If they have a high-grade stenosis, that's great. But if they fall in between, then you're left with the question is, okay, I see it, but is it functionally significant? So if you see that, then they probably may still need a secondary test, like a functional test, or maybe eventually going to the cath lab and getting invasive FFR. So I think if CT FFR actually becomes more streamlined and it's takes off, then that would allow CT to be used more throughout from low, intermediate to high risk patients. And the other issue too is if you have a lot of calcium, so if you have a patient that has a lot of calcium or prior stents, and if they're small stents, it can be hard to really visualize those coronary arteries. So that's where having a functional component like FFRCT can help. So I think really the not having a functional component does limit its widespread use beyond just sort of the low intermediate risk population we have now.
So Hans, it seems like in the promise trial, a lot more patients get stented, but they don't derive any real clinical benefit from it. Is there any comment on that?
But we know that, I think. You know, if you stent stable chest pain or stable, there's no clinical improvement in outcomes.
It seems like the CAT scan, though, is leading you to put more stents in.
So,
You don't know that they don't feel better.
Yeah.
This is like you live or die. It's the same chest all the time. Yeah, it may be good for him.
Yeah, and you know, if SCOT-HEART followed the patients for 5 years, you know, if PROMISE followed them up for 5 years, it's possible that cath and revascularization rates will even out. You know, in SCOT-HEART early on, there was high rates of cath and revascularization, and then after 5 years, it evened out. So if you followed PROMISE for 5 years, you may see that similar trend. Unfortunately, there won't be the 5-year follow-up data, so it just stops.
That really was a good talk. And getting back to the issue of the calcium in particular, apparently there's a new sort of analysis of the PROMISE data suggesting that in older patients, CT doesn't do so well compared to functional stress testing. Functional stress testing, from what I understand, mostly nuclear. But in younger patients, actually, it is better, presumably because there's just not as much calcium to obscure the scan. So do you think that we should sort of decide on our testing based on age?
That's a good question. I think there's more. I mean, I think there's more that goes into. I mean, the question is, you know, can we figure out or predict if the patient is going to have a lot of calcium that will affect the scan? I don't know. I mean, I guess I don't really know if we can just use age as the cutoff. There's probably other factors to take into account to predict that. Another interesting that has been brought up or that is done in other places is doing a coronary calcium scan prior to the CTA to sort of help triage. And if you have a really high coronary calcium scan and you have high coronary calcium, and this is just a non-contrast scan with low radiation, sort of a SCOUT film, and that would be a way to triage those patients and say if your coronary calcium score is above 400, maybe CTA is not the best test for you. If you have a really low calcium score, then they would proceed through the CTA. So that's been one way that I've seen, at least done clinically, as opposed to the age. But again, that would be having the patients undergo sort of an additional upfront scan to make that call. I don't know if you have...
There's one other interesting comment. So if you think our insurance is really screwed up, here's yet another instance. If you order a calcium score followed by a CT angiogram, because the calcium score in many ways is considered experimental, that means both the calcium score and the CTA are considered experimental, so they won't pay you. So New York University actually figured that out when 6 months of CTAs were not paid for. So it's just like your brain falls out of your head, right? Because it just doesn't make any sense. Because you want to get the you want to get the prognostic data, and then you want to get the CTA, and then you want to stratify like this. But if you do that, you don't get paid. Or at least there are very few payers that will actually do that. So it's unfortunately not a very good way. Now, what I will say is that if you're trying to do a pretest probability, there is a score out there, which is actually part of the UW chest pain algorithm. There's something called CTA Consortium 2, which takes risk factors, puts that in there and says your probability of having obstructive coronary disease. And that's actually worked into the UW chest pain algorithm to say that for those people that have a high risk for obstructive coronary disease, probably shouldn't go to the CT scanner first. And so we try to risk stratify those patients out because if they have more than a 50% risk, maybe CTA wouldn't be best because you're just going to be stacking tests and you should go to functional study first. So there are some algorithms that are out there and those are continually refined based on risk factors, but a calcium score would be the most reasonable thing. We just can't get it. Now, you might want to tell it about this because this was something that we're very proud of. The CT First people that I work with at the Society of Cardiovascular CT actually came up with this, which is Hans.
So this is the insurance map, because I think oftentimes we want to order a CTA, and the question is it covered by insurance? And this is it's an interactive map, and you can go to the SCCT website. you can click on the state. So you click on Washington and it'll pull up all the different insurance providers. And then you would click on the insurance provider of your patient. And then it would go through all the indications for the CTA. So what are the indications that would cover the CTA? So you would really have that answer in clinic, as you're deciding whether or not to order the study.
Yeah. If you really want to get it covered, just say rule out coronary anomaly.
Yep.
And they always have to cover it. It's a get out of jail free card.
Well,
Go ahead.
This raises another interesting issue of sort
We
of
always have to
our
rule it out.
functional and anatomical asking different questions entirely, and microvascular ischemia, small vessel disease, all that sort of thing. How do we sort of use those testing in a more refined way?
I mean, how do we choose between the two?
So the CTA will not pick up microvascular disease most of the time in its current iteration.
Yeah.
But functional stress might.
Yeah. So I mean, I think one way to sort of combine them potentially. I don't know if I have the answer on how best to combine the two or use them. I think it just gets back to the simple question of, what are you clinically getting the test for? If it's microvascular disease, CTA probably isn't the best test, and you would do, a nuclear PET stress test. If you want to know if the patient has coronary disease or not, and you can rule it out, I think CTA answers that question. If you want to know exercise capacity, functional capacity, CTA doesn't answer the question. So I think it just gets back to what the indication is.
I'll give you a real cutting edge issue. Adam Alessio and Mike Binscharler and I actually put in an R01 in order to look for microvascular disease, specifically with CT. Unfortunately, that was not funded. However, what did come out of it is that we've developed a way to actually do quantitative CT perfusion using 2 to 3 scans. So you get your CTA, you get 2 other scans, which actually allow you not only to do qualitative, just looking at it, see whether or not the contrast is there, but actually do quantitative. And so that's part of and actually we were awarded a 1-year grant from the NIH. They actually gave us a year in order to further develop this, so there can be something to it. But we're going to revamp it, and we're looking for patients with retinopathy, because those patients, by definition, have microvascular disease that's visualizable. We think it's going to translate to the heart. So we may have some more data coming out from us. I think one more question.
Yeah. Can you give us some idea of what the progression of disease would be in sort of low, intermediate risk group, or let's say if you studied a person one year and then did the same study again in 5 or 10 years? What's the progression that you've been able to find out?
Well, I think I can maybe answer that question for a coronary calcium score looking at atherosclerotic burden. And it does seem that the calcium increases by about 20% per year in sort of the normal range. The question about like coronary CTA and how does plaque progress, I don't know that off the top of my head. I don't know if you have that. But yeah, I mean, if someone has a normal or 0 calcium on their calcium score at 0, usually they say around 5 years is where the majority of people will start to show calcium and go from a 0 to a positive score. And if you're older, that's going to increase a little bit faster than if you're younger. And if you have calcium, they usually say every year there's a 20% increase or so in the level of calcium based off of that score.
Okay. All right. Thank you very much.